Hi, everyone. Welcome to Tuesday Night Rheumatology. This week, it's not Grand Rounds, it's Journal Club with Artie Kavnaugh from UCSD. Hey, Artie.
Hey, Jack. Glad to be here.
Yep, wherever we are in the Ethernet, you from San Diego, me from my office in Dallas, and 300-400 of our best friends watching us, and they're going to join in the conversation. Folks, we're going to get to Artie's journal article in a minute, but I want to start off with a few items that we can discuss. But when we do get to Artie's presentation, feel free to ask questions. While we may, and we're going to be talking about lupus and the use of steroids going forward, and that should be the bulk of your questions. But if you want to ask us about tomorrow's weather in Wichita, we could take a stab at it. No reason to do that. So for that, you're going to use the Q&A button on the bottom, not the chat button. Don't raise your hand. I'm not paying attention to it, but we will get your questions and go through as many as we can in the last half hour. Artie, I want to start off with one of the reasons why we're here is, life has changed. Education's become difficult. You're at a major university with a major teaching program. How has education changed, and how are you educating the fellows at UCSD?
Well, it's certainly a difficult time, and I think as Alan Matsumoto said a couple of weeks ago on Room Now, it's something that's a skill set we're learning, and we've gone, of course, I think as everybody has, to virtual grand rounds, which actually they work pretty good. It sure feels not as good as sitting there with people, but the grand rounds part of it seems good. I think the clinics are sort of taking a bit of a hit because there's a little bit fewer patients, and because at the start we were really distant from each other, and it's hard to learn in that atmosphere. We have, like I think a lot of traditional teaching clinics do, we have a big room, and the attendings are there, and the fellows come in, and we talk about patients and say, hey, what do you think about, hey, look at this x-ray. We're starting to get a little bit more back into that, trying to social distance while being close enough to each other to get that sort of camaraderie, which I think is an important part of this apprenticeship that is rheumatology education. So we're heading back toward there. We certainly encourage the fellows to take advantage of all the resources. The ACR put together a teaching program that has been very well received by the fellows. We still talk about the newest journal articles and what's coming out. So I think it's a scramble. But I think we're doing it, and I think everybody else is probably doing the same.
So I know you to be a voracious reader and consumer of data and information, and you do all that while you're in the high skies, traveling to wherever your next lecture is or meeting. And that's where you get a lot of work done. Now, since you're working from home, has it changed how you read and cover the journals?
Well, in a way, though, of course, it has. I mean, it's a different universe. But the good part about being on a plane was that you're alone. You had time where people aren't really bugging you. And now with so much time, there are large parts of the day where whether it's reading journals or cleaning out the file cabinet or doing other things, there is a lot of time, and so I think that has replaced it. And I keep up with the journals as good as I did when I was taking them on a plane. It was really the going to work part. That was what got interfere with the journal reading.
So we have a few reports this week, including today, 2 new reports about IL-6, and that they might work in patients with not necessarily cytokine storm, but in severe patients with the COVID-19 infection. These are in the JAMA Open Network publication. And then we had an early report from the VA Center about hydroxychloroquine, and another report about chloroquine having a higher death rate. And all of these are basically early reports, almost preprints, or really even news headlines. The one I wrote about today was from a French newspaper. And the author said, we have an obligation to put this stuff out there. It's ethical for us to do this. We're going to get it published, but we're putting our data out now. 129 patients, treated with tocilizumab. It looked like they did better if they were on tocilizumab than not on tocilizumab. But the idea is, I'm going to bring up a quote from one of the editorialists who wrote, amidst the torrent of data that's coming out right now, seems like the half-life of information is making this really, really difficult. So, is it right to be reporting on these, studies that are almost fully done? A lot of them actually aren't. They're interim analyses, and we're getting almost like a preprint. Is that right to put it out there, or should we be holding back and saying, I'm not believing it until I see the real study?
Yeah, it's a difficult one. I read on Room Now, I read those reports, including the French one, and exactly as you said, they framed it in an ethical standpoint and said, it's too important. We can't not have this data out. But before it's vetted, it has a danger of causing more harm than good. So I think things are being rushed a little bit. And you see, chloroquine was the savior. Now it's the devil. Then it's the savior maybe for a couple of people. And of course, the same with the IL-6 inhibitors. It makes a lot of sense that they could work. But I think premature data, I don't know that necessarily helps us.
Yeah, I think it's like the days when you really can't get the results of how to treat inflammatory myositis. The best you can do is some kind of either claims data analysis or database analysis. And, they're not proof of principle. They're hypothesis generating and help you to lean. But unless you have nothing else to lean on, it's the best you can do. And that right now is the best we can do. Let's get to today's journal article. Artie, go ahead.
But, things come and go in medicine. Remember magnesium sulfate as a therapy. You get old like us, prednisone, it's either saving sepsis or killing sepsis, and then it's saving it, and then things come back and forth, hormone replacement. So these high publicity anecdotes, which have not been methodologically shaken out, they're not the strongest data, and that's the kind of data that gets overturned.
Okay. Yeah, we still are heavily reliant on real journal articles from real journals to give us our best guidance. Speaking of journal articles, this is our article for today. It's ARD. The title of it is Withdrawal of Low-Dose Prednisone in SLE Patients with a Clinically Quiescent Disease for More Than 1 Year, randomized clinical trial by Mathian, Alexis et al. I'm going to turn the screen over to Artie. Actually, I'm going to be controlling the screen, and Artie's going to be narrating the slides as we go forward. So let's do that. Let me see. Which one do I want to show? I got too many open slides. All right, not that one. This is the one we want. There we go. All right, here we go, folks.
As you're getting the slides ready, Jack, let me take a little commercial tangent here, which I wouldn't normally do, but I swear, hand to God, 15 minutes ago I was cleaning out some old files, and it's a mixture, stuff that you saved over the years, receipts, pay stubs, certifications, evaluations from 2006. And in that file, and I said, if it wasn't 15 minutes before the show, I wouldn't have probably said anything about it, but I found this. Ask the experts. And look at that handsome young purple lad there. This is John J. Cush right there, back in the day. So I'm saving this bad boy. But it's amazing the stuff that you have in your files that you haven't looked at for a number of years.
You need a bonfire fire cell.
So speaking of old things, prednisone. Prednisone, it's the therapy that's defined rheumatology for more than half a century now, and we're still arguing about what the most proper place of it is. And this is an abstract that was presented at EULAR, and now it's just been published in the Annals of Rheumatic Disease. The withdrawal of low-dose prednisone in lupus patients, and I think prednisone. I always say it's the secret of rheumatologists. If you ask rheumatologists how many of your lupus patients take prednisone chronically, we know the answer is not supposed to be a lot. We know that we're supposed to get people off prednisone. That's what we're supposed to do. But if you look at our charts, it's probably 60-70% of people. I remember Jack and I were in the lupus clinic in UT Southwestern in Dallas, and someone asked, well, what do you do with your prednisone? I said, we taper it. This is how we taper it. Boom. And everybody's off by a year. And then you look in the charts and there's a lot of people who are still on it. So I think, many of us would say, well, what happens, especially when people are doing very well? Because you have the the potential risk of the disease acting up versus the toxicity of the steroids. In registries, there's 60, 70, 80% of patients who are on low-dose prednisone. And to me, that rings true in that you have Mrs. Jones come and you want to get off the prednisone, but just not right now because she's got a travel coming, she's going on a cruise, something else is going up. So we always do it slower than we should. Our societies tell us we should be getting people off prednisone. The most recent EULAR recommendations in 2019 said withdrawal when possible. So this study addresses that in, I think, a very nice way. It's the CorticoLoop study. It's single center. 124 patients with clinically quiescent lupus for 12 months or more who were on 5 milligrams a day. So what is clinically quiescent? Well, clinically quiescent is pretty low disease. So the SLEDI-2K less than or equal to 4. The BILAG, which covers pretty much every aspect of lupus that could exist, had to be a D or an E in all systems except some non-significant hematologic manifestations, like someone who's always lymphopenic, they could be lymphopenic. The physician global assessment had to be 0, very important. They were on prednisone 5 milligrams a day. They were allowed to be on other medicines, hydroxychloroquine, azathioprine, mycophenolate, but that had to be stable for a year or more. Now, it is an open label study, and they were randomized to either continue the prednisone or to withdraw. A nice aspect of the study, especially because the people have been on this prednisone a while, is that they gave people hydrocortisone for the first month, 20 milligrams a day, just to make sure that adrenal insufficiency was being flagged as a lupus flare. And they tested a few people and found that that was not the case. Primary endpoint of the study was any flare according to the revised Selena-SLEDI flare index over 52 weeks. And it was powered to be a superiority study. And with that, they ended up saying they needed about just over 120 patients, which is what they achieved. So the patients were evaluated every 3 months and looking specifically for signs and symptoms consistent with the flare. Treatment could be changed only for occurrence of adverse events related to the medicine or for a flare. And they didn't consider isolated serologic changes a flare. So changes in the dsDNA, changes in the complements were not considered a flare. So who did they put in the study? 63 people ended up in the open label prednisone withdrawal group. 61 patients maintained prednisone. The table 1 of the paper really very comparable. They achieved it. Randomization worked. They had very comparable characteristics. The age mean was 42, 90% women, long disease, long duration of lupus, so more than 12 years. They had been quiescent, importantly, for a long time. So 62 months was the mean duration of clinical quiescence, and the mean Selena-SLEDI was 1.5. That's virtually, as anybody who's used the SLEDI form knows, that basically gets you 0 or 1 thing at all. So there's not a lot. What did they have? They had, a lot of the patients had arthritis, 80%. 60% had dermatologic complications of lupus nephritis in 37%, serositis in 25%, and then smaller numbers with the cerebritis, et cetera. Low complements, 28% at baseline, high double-stranded DNA, 47%, and both in 16% of patients. That's an interesting subset of people who, as the Canadians call them, would be clinically quiescent, serologically active lupus. Treatment, 92% on hydroxychloroquine, as you would have guessed. In this group of patients with a lot of skin and joint stuff, mycophenolate, 13%, azathioprine, an additional 3%, and methotrexate, 10%. The steroids have been used for 141 months, so almost 12 years. What are the data? What's the data? What did we learn from this? Well, the people who withdrew the prednisone flared more. 20% of them, 17 out of 63, flared, compared to 7%, or 4 out of 61, which was highly statistically significant. Now, they looked at, of course, at some secondary endpoints. Mild or moderate flare was 12 patients versus 3, which was also statistically significant. And severe flare, 5 patients versus 1, small numbers and not statistically significant. They looked at other definitions of flare using the bilag, for example, and found very similar results. Changes in serology were not very predictive of who would flare. They didn't find any difference in the damage index. The flares were very often what the person had had before. The patients had arthritis, many of them. So arthritis was the most common, skin disease, the second most common, and glomerulonephritis were 3 patients of those who flared. So there were no predictors of who would flare. As I said, serologically it didn't predict, duration of steroids didn't predict, concomitant medicines didn't predict, other than the withdrawal of prednisone. Now, the key question in everybody's mind, well, what about toxicity? Isn't it better to get off prednisone for considerations of adverse events? Well, they didn't have a lot of adverse events, which again sort of makes sense when you think about the long duration of treatment and the low dose. This is 5 milligrams that we're looking at. They looked at the glucocorticoid toxicity index, and changes in that index, worsening in that index, was not different between the 2 groups. So the conclusions that they had is, I think, hard to argue with, and that is that withdrawal of low-dose prednisone in people who were pretty much rock stable for a long time, 5 milligrams of prednisone, if we withdraw it, they are much more likely to flare, and some of them mild to moderate, and some of them severe. Now, on the you know what, I haven't been adjusting the slide, so let me back up. Rookie mistake here. Let's go to the second slide, which has the things I've just been reading off and talking about. This is the setup and said, why should you do this? Next slide shows the, if you go to the next slide, that has the baseline characteristics, which I read all of these, very comparable, the concomitant therapies. Then go to the next slide. This is the data slide that shows all the information. Next slide. And here's the survival plots, really showing the stark difference between those who, and this is the main outcome, primary outcome, this is probability of flare. Patients who withdrew, many more of them flared compared to those who did not withdraw. So the overall conclusion is that withdrawing low-dose prednisone in people who've been on it for a very long time, very stable at that dose, can be associated with the flare. So an interesting aside also on the next slide, as this journal club was posted, Cindy Arano reached out and said, this is something I did years ago. And she sent me an article that she had written, published in the Scandinavian Journal of Rheumatology, which wasn't picked up, should have been referenced by these authors, but was not. This was a review they did back in the day, retrospective chart review, 22 lupus patients who had a flare, or 2 of them had, 2 patients had more than 1 flare. They were in prolonged inactive disease, which was actually defined by use of low-dose prednisone, and they were looking at them for see who flared. And again, flaring was defined by needing 20 milligrams or more prednisone for 3 consecutive months. So they had, of these patients, 6 had major flares, 18 did not. Again, these are people with active lupus that was treated. Now they're in prolonged inactive disease on very low doses of prednisone, presumably doing very, very well. What they found is that fewer flares were associated with people who had been on a higher dose for a longer period of time of steroids when they were active. Concomitant azathioprine and hydroxychloroquine. Concomitant azathioprine, 33% use by those who didn't flare, 17% by those who did. Plaquenil as well, 44% for people who didn't flare, 17% who did. And interestingly, 5 of the 6 people who were flaring had tapered off prednisone completely. Remember, they were on 0 to 5. Most of them were on 5. When those who tapered to 0 had much higher incidence, it looks like, of having a flare. So it looks as if these data really go along with the data that we just said from the Annals of Rheumatic Disease paper, and that is that you may want to keep some people on long-term prednisone. In this, they didn't find a dramatic difference in the tapering from the low-dose steroids. So a little bit more in those who stayed on prednisone in terms of steroid-related adverse events. So I really love that Dr. Aronow forwarded this, and it brought a warm fuzzy to my heart, because I've been there when you've done a paper and nobody knows about it. And there was a study that we did at UT Southwestern, and Jack remembers this one very well. This was the HELP trial, the hydroxychloroquine effects on lipoprotein profile. So we did this study, we set it up, did it all internally, got drug and matching placebo from the manufacturer, and got an endocrinologist, Margot Denke, got a nutritionist, got a statistician, all really kind of putting their time in on a voluntary basis. It was an investigator-initiated study with no money behind it. And we did show that in a double-blind study that, in placebo-controlled study, that hydroxychloroquine had a significant benefit on decreasing lipoprotein levels. This was published in the Journal of Clinical Rheumatology in 1997. And for any of you who want, and actually some investigators from Quebec reached out to me last year, and they found the paper, and that just brought a tear to my eye. And they asked me if I could send them the data, and I said I would love to send you the data. Let me find the file for that, and I did find the file for that on something that was like this. And for those of you who youngins that are listening, public service announcement. You know when you save something on a computer and you see something that kind of looks like this, and you wonder, what the hell is that thing? Well, this is, we called them floppy disks. They're not floppy, they're pretty hard, but the ones before this were floppy, the 5 1/4 inch. These are 3.5 inch. This holds 1.44 megabytes. So that's enough for a couple of files and maybe a very, very poor quality picture these days. But anyway, I tried to send the files. Trouble is they were in a program called Lotus 123, which only Jack knows, because Jack was the Lotus 123 maven. But anyway, sometimes you do things and it's really nice to get to hear back that somebody paid attention to it years from now. So bottom line on the next slide, if you will, is that here's if we go to there, the withdrawal of low-dose prednisone is in patients who are doing really well on prednisone for a really long time, very low disease activity. You stop that 5 milligrams of prednisone, they're going to flare. And what do you do with that data? And I'm going to ask Jack this. You could look at it and say, well, 73% of the patients didn't flare. So why don't you just stop the prednisone and see what it does? And other people may say, well, why do that? Why not just keep that low dose prednisone? Because the toxicity didn't seem to be a real tremendous burden, although it wasn't really assessed over a long period of time. So I think very well done. Beautifully done study. I really like this. I think it raises questions, and I'd love to hear discussion. Jack, what do you think of it on this topic?
Well, I think we're getting a lot of questions on this. I want to remind everyone next week, Len Calabrese is going to do our grand rounds, and he's going to talk about IL-6 in health and disease. But this week, it's still just you and I. And I like the paper too, because it fed a belief that I developed over many years of working with you and Peter Lipsky in the lupus clinic. And, you know, we had an incredible lupus clinic, lots and lots of patients at Parkland. And I mean, I don't know that I would have done as well managing lupus if I wasn't allowed to keep people on 2.5 or 5 or even 7 milligrams of prednisone, because it was the great equalizer. Otherwise, everybody's in the hospital, or we're using more consultants or whatnot. So this boils down to an old mentality, mind mentality of keep them on the prednisone, supported by this data. I love this data. But if we had Michelle Petrie here, she'd be ranting about we don't need to use prednisone these days to manage our patients with lupus, and that the goal should be steroid-free management. Yes, steroid plays a very important role, but can we really get around to steroid-free management of lupus? What do you think?
Well, I think it's interesting you mentioned Michelle, because one of our other passions is hydroxychloroquine is very safe, but which I believe as well. But these days, especially with the change in how the ophthalmologists consider this, I find myself with getting hydroxychloroquine taken off the plate for some patients, because they go to the ophthalmologist and all they hear is blah, 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 blind, blah, 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 and they won't take the medicine anymore. And that's kind of this population. 15 years of lupus, doing well with active manifestations in the past that would respond to hydroxychloroquine. So we have, how many other options do we have? We do have belimumab available to us now. We have other options, but you're going to give somebody who is this kind of a patient mycophenolate. Some of them are on it. You give them methotrexate. Well, that's so I think this makes me reevaluate. Writing at the bottom of every note, taper off prednisone next time. Which
yeah, the question is, would these results have looked the same if this was a 5-year study? So we learned in RA that flares have a cumulative effect, right? And we tend to think of as flares and flare management as sort of a knee-jerk response. If this, then that, give more steroids, get them over the hump and move on. But there's a cumulative effect to flares in RA, especially when you're relying on one agent only, which is steroids. I don't know that we know that we can afford to take them off and then manage a whole lot more flares.
Yeah, and I agree with you 100%. I think the same issue with lupus. You take them off 5 and they flare. Well, maybe they're miserable. And then what do? Then you put them back. Generally, I think a lot of us would go higher and give them 15 or 20, or some people might even say higher, to get that capture, get them doing well again, get them back to 5. So in the meantime, for some people, you're using more steroid than you would have likely if they had just stayed on the 5. So,
the graph that you showed on the primary endpoint in that last slide showed that the ones who stayed on steroids still had a flare rate, although it occurred at a lower level and it occurred late, right?
Yeah.
Suggesting that over time, there's an inherent propensity for lupus patients to flare. We know that. But that taking them off the steroids just sort of accelerates that and magnifies it a little bit to the point where it looks bad on paper and it could be clinically bothersome to manage. And the question is, what do patients want?
Yeah, no, and as you alluded to, I think you could say the same in rheumatoid arthritis. We know the studies with the tocilizumab, where if you looked at the people who were removed from the steroids, very similar data in that a lot of people did well and did fine off the steroids, but some of those flared more so than the ones who stayed on the prednisone. And it's the same thing. What is it going to take to capture them, to get them back under control?
All right, so let's go some questions here. Let's do some questions on this before we get to life and corona. But do you believe in the BILAG scoring system? Does it have any utility for you? I mean, you do lupus trials and you understand it. The rest of us, it's like a bunch of nonsense that I don't need to know about. But do you believe in it or other outcome measures in lupus?
Yeah, I am involved in a lot of lupus studies, mainly because my colleague, Dr. Ken Clooney, is a renowned lupus expert. And so he's often the PI of the study, which means that I will sometimes have to do the BILAG, and it's awful. It's absolutely horrible. Wait, does this go internationally?
Just above into Canada only,
Okay.
Not across the Atlantic.
No, I'm not saying anything anybody hasn't already said. I mean, it's the Rube Goldberg of assessments, and it has an inherent complexity that pretty much guarantees that you're going to have logical errors. You can't go from very severe to gone. You have to go to improving first. So and then in a research study, it's awful because you're really looking at this a year later and saying, well, Mrs. Jones, she went from this to this and she didn't go into the in-between. And it is very comprehensive. I think it was a great idea to be able to really look at every potential facet of lupus and look at it in a way that the clinicians, it is meaningful. Are you changing therapy based on this manifestation? But it's completely unwieldy, completely, I think, unpractical, never ever used in the clinic. And, when are they going to move, as rheumatoid did, to getting something that you really can do in the clinic so that you're not just doing something for looking at a journal article and looking at an outcome and then saying, well, I'm not doing that. And RA has kind of gone the other way. And I think lupus has got to go that way. And I know a lot of people, including Ken and Cindy Arano, and a lot of people are working on trying to get something. And it's difficult because it's a heterogeneous disease. And in that way, RA is a lot easier. But no, I don't think the BioLag has any use in the clinic.
Okay. So a number of questions on how fast were the steroids tapered, and Tony Russell says, surely in people who've been on steroids for 12 years, you need to tail down very slowly and not just stop them. So in this study, how are they tapered, and what do you really do?
Well, they were stopped from that, and they did think about adrenal insufficiency.
It went from 5 to 0?
Yeah.
Okay.
I got the article. I got the article here. Yeah, they tapered them off, and they did give them 20 milligrams of hydrocortisone for the first month, and they did ACTH simulation tests on several people, like a handful of people, for whom there was a question: is this a lupus flare versus adrenal insufficiency? And it was not adrenal insufficiency. So, and the to find data on the prednisone withdrawal, you really have to go back a long ways in rheumatological history. I remember looking this up many years ago as an allergy fellow, and it's interesting because, of course, the history of steroids, people use more and more and more. People are feeling fantastic. Then they went for orthopedic surgery to replace the crippled joint that was now holding them back because of the damage, not because of the inflammation. They went in the hospital. No one knew about steroid withdrawal, and boom, that's when they found out about it. But I remember an article from the late 70s that actually looked at acutely stopping people on much higher doses, and most people do not go into adrenal insufficiency. It's become standard practice for anesthesiologists to use replacement for anybody who's on certainly higher doses of prednisone. It's interesting, though, the practice isn't necessarily, I think somebody on 3 or 4, I've seen the anesthesiologist say, no, they don't need to do that. So I think we worry about the adrenal insufficiency always, but I don't think it happens nearly as much as we worry about.
So this study was an open label trial, meaning that those who were randomized to continue were, okay, we're continuing, it's status quo. But those who are randomized to withdrawal, do you think that could have biased this? That they might have thought of themselves either as pioneers or being persecuted, and could that have changed the outcomes here?
Sure, and it's always something you think about in an open study. I'm not going to flare because I'm still on the prednisone, whereas the other people, you're taking away a medicine that I've been on for a while, but I think that's always an issue in rheumatologic diseases. The most common flares were the same things that they had before, the arthritis and the dermatologic manifestations. But some people had a flare of glomerular nephritis. It'd be better, and it would have made that perfect study if it was blinded with a prednisone placebo.
Andy Weinberger asked, what about the abrupt cessation? Would the study maybe have looked different if we had done a gradual taper as we would normally do, or would it just delayed the inevitable?
Impossible to know. That's a great point. What about if you had gotten to, do they need 5? And it's interesting because I always look back, to the work of Gus Escalante and UT San Antonio, who's done a ton of work on the toxicities of prednisone, looking particularly at the cardiovascular, and to say what is a safe dose. And I'm not sure exactly where I get it from, but what I tell patients is 3 or 4. That you get down to 3, I don't think there are side effects of the prednisone. So if you want to stay at 3 forever, God bless. Especially if you're 70 years old and you have other issues going on. So what if they had done? I mean, that's if you had gone, if you gone slowly, what if some of the people went to 2.5 instead of going to 0? Would 2.5 have been in between, or would have had the same staying power as the 5 milligrams did? I don't think we know this. Those are interesting questions. I personally I like to get people below 5. I'm happier at 4 than at 5, although I have trouble, and I can't support that with a lot of good data, that's for sure.
So again, this is sort of mind-bending, nerve-wracking, puts my brain in a pretzel. What's worse, the chronic toxicity of 5 milligrams of prednisone, which might be something, who knows, maybe in bad people would be something, and maybe in good people it wouldn't be so much, versus the consequences of flares being off. And then in the background, you have, you know, mavens like Michelle telling us that we really need to manage our lupus patients more aggressively and not rely more on steroids. This is, again, it's a tough one for the rheumatologists, and I think what I hope comes out of this is that everyone rethinks their strategy, because being comfortable where you are may not be the right thing for the patient.
Yeah, and you say, well, these patients, they should have watched them longer to see if there was less avascular necrosis in the people who discontinued. And I find myself telling patients that prednisone is a sneaky drug. You could be on it for a while and pop up with a side effect, unlike most people are going to have a side effect for a medicine that they have it really early on in the course. But prednisone does things that can sneak up on you. Shingles, I didn't see reported specifically for this, but low doses of prednisone always pop up as a risk for that. So if they had followed them longer term, would they have found a difference for some of these side effects that, besides the bothersome ones about the weight gain and the Cushing-like appearance and stuff?
So Art Weinstein points out 73% of patients did not flare after withdrawal. So isn't the issue going to be here that we need to know who those people are and who the people who do flare are? So is there you think there's a futuristic way of figuring that out? Is it going to be the proverbial biomarker, which I'm tired of people talking about it and it not showing up like I need it? But I mean, what do you think? Can we ever predict who, or is this just a taste test? You got to do it and find out.
It'd be, I think for right now, it's you have to do it and see if there is a flare. It'd be awesome. It'd be awesome if there was a test to do it. But I think this discussion highlights one of the things about biomarkers is they have to be really strong and they have to apply to most of the population that you're interested in. Otherwise, you don't care. So talked with Jeff Curtis, and we looked at these more in RA patients, but it has to apply to 85+% of the population that you're looking at. Otherwise, you're not going to do it. If it's 60-40, that's not worth that test isn't going to help you. You're just as good just trying it and see if it works. Yeah.
Do you think that patients on certain regimens like Benlysta or mycophenolate with hydroxychloroquine that are more apt to successfully withdraw, or is it the same story? You just have to try.
Well, in this group, they were well balanced, so well balanced that they couldn't dissect out that effect. In Cindy's old paper, which they looked at it in a different way, they did find an effect of concomitant medications, and those people on the azathioprine or the Plaquenil flared less than, as did those who got treated more aggressively when their disease was active. So this study, because it was randomized, you didn't have that effect because the groups were evenly matched for exposure to things. So that's an important question. I think all of us would feel much better tapering the prednisone if they were on something else and able to stay on something else that was helping control their lupus.
Yeah. Do you think there's any role, Tanya Doan asks, is there any role for using hydrocortisone with prednisone when you want to stop like this to cover adrenal insufficiency, or is this just a facet of a clinical trial that has no clinical applicability?
I like it just as they said to try to dissect out, is this a flare? And I think that's what we do. We tell our patients, don't we, when we're tapering prednisone, like, be cognizant that if you're tapering prednisone and you feel like your get up and go is gone, that could be the steroid. So maybe hang in there and see. And if after a week or so you feel fine, then continue the taper. Whereas if you have a new rash, that's not a adrenal insufficiency. That's the lupus acting up because you had the rash before and was treated. Now it's coming back. So I warn the patients, I don't treat with the cortisone, and I don't have a great reason not to accept that. I think that the adrenal insufficiency, it's horrible when it does happen, but it's really infrequent, even on people who are chronically on much higher doses.
So to get back your giddy up, what dose of hydrocortisone was used here for the first month?
20
a day. Okay, interesting. Someone's asking, actually, Martina Ziegenbein asked, what do you and I do with our low-dose prednisone long-term? I'll start out, so low-dose prednisone long-term, we're talking about lupus patients here specifically. I have always tended to rely on low-dose prednisone. So my patients have serious disease, not a little bit of aches and pain and mild skin stuff, but people who have multi-organ disease for which I'm going beyond hydroxychloroquine. I usually would strive to get them down to 5 or 2.5 a day and never change it. This paper sort of supports that, but I'm now swayed by some of the other evidence that says that maybe I should try to get them. So I think that the protocol that here where people were in remission for 6 months, or in this case, 12 months, with a low disease activity state, I think that they're inviting you to make a change. And I think I'm going to go back to my fellowship days of thinking like I should get them off of steroids if I can.
Yeah, I think that I would say still, I mean, how can you put in a chart, I'm just going to keep the prednisone forever? You were always thinking we're going to taper it. I probably, in people in a population such as this, I'd probably chicken out and go to 4 and then go to 3 and then go to 2, thinking that for Mrs. Smith, she'll go to 0 and do fine, but Mrs. Jones, she flares if she can't get below 3, and for some reason that makes me happier to be at 3 than at 5.
I'm actually much younger than I look. I have my hair colored this way, but Richard Jones at UAV says Graciela Alarcon would not be ranting. She'd be congratulating us because she's often said during his fellowship and after that it's wrong to remove steroids from people with severe lupus. And there are a lot of people in the old school. Ted Pincus was one of them. I know that I've been one of them. Morris Ziff taught me, and I think that our whole clan was this way. Is this an artifact of aging and that we need a newer, fresher approach here to better manage lupus going forward?
I think one of the differences for older folks and the younger folks, and I'll admit it readily, younger folks are way better about things like glucocorticoid-induced osteoporosis. They're all over that. And if that's in the back of your mind, then the lowest the dose you can get to, the better. I think one of the things that's been, I think shouldn't be surprising. I don't think it was surprising, but all the discussion of Zoster, particularly around the JAK inhibitors, and yet when you look at it, it's all the prednisone is always a confounder in that. You look at GI perforations, IL-6 inhibitors, prednisone is always in there with that. So I think it's still, I think some people can't get off it, and certainly if they have no other alternatives. But I still probably, as Art just said, 73% of the people could taper. So, you glass 3/4 empty or 3/4 full or 1/4 empty or 1/4 full.
Cindy Weaver asked about, do we check hydroxychloroquine levels in your lupus patients?
I haven't. I know Michelle has published a lot on that, and there are very good correlations with levels and outcomes. But I think it's really, it's kind of a sneaky way of checking for compliance, isn't it? I don't think there's not large genetic variations in how people metabolize, not like azathioprine, for example. So I don't know. I always feel bad. I haven't really, I don't know that I've done it with hydroxychloroquine, because it's sort of a sneaky way to say, aha, I know you're not taking it.
Yeah, and I mean, the numbers on lupus non-compliance by hydroxychloroquine are astounding. I mean, as much as 80% are non-compliant in some studies, and as little as 40% in most studies are non-compliant. And yeah, you'd be showing that. That's not who we're talking about in this particular study, because we don't know about their compliance. We do know that they were in a very good state for over a year, and compliance wasn't really the question. In fact, they were doing so well they could stop the steroids, and you might have made different study to actually stop the hydroxychloroquine.
Well, that's a fascinating point, Jack, that you could raise about this study. I think all of us have the sense, and I think there is some data to support it in some studies in rheumatoid arthritis. When people get in the study, they behave better. And maybe there's better compliance with the 92% of people who are on hydroxychloroquine. And maybe if they were not compliant, then the disparity in flares would have been that much greater. You know, you don't know. And compliance, you know, other than those bottles that tell you when they open the pill, or you know, some other fancy intrusive method, you're still just asking the patient if they're compliant.
Well, non-compliant patients are actually as smart as the rest of us, so they find ways around that to fake the system. One of our viewers is asking about our views on their concerns for low-dose steroids being an increased risk factor for infection. My view on that is 5 milligrams of prednisone probably does not increase your risk of infection unless you're someone who's sick. Someone who's really sick with comorbidities and other reasons to have an infectious risk, uncontrolled disease. 5 milligrams of prednisone adds to your risk, in my opinion. But if someone's doing really, really well, there's very little evidence that 5 milligrams or less is going to add to an infectious risk. What do you think?
Yeah, I think the problem is we don't have a ton of data, and you will find data that says 5 milligrams, and 5 milligrams is associated with an increased risk of infections. But it's sort of, we don't have fine dosing data. Is 3 safer? 10 does seem to be worse. 15 definitely seems to be worse. So I don't know if 5 is clear of any risk of serious infections, but I think that the comorbidities, the concomitant medications are likely more important.
So based on this trial, when you have someone and you say, oh, well, you've been in remission now for 18 months and you're on 5 milligrams of prednisone, 4 milligrams, would you be stopping it abruptly, or would you, what would you do?
I'd probably still go to either 4 for people who have a little OCD, which you have to take 4 1 milligram pills every day, as compared to like 2.5. I would still probably taper. I like the every other day taper as a sort of a gentle way. And that way, to me, you're sorting out the adrenal insufficiency issues, and you're really seeing if there is any benefit to them being on a low dose, lower than 5. So I'd probably still not just stop abruptly.
Okay. Let me ask you a question about practice. I don't know about you guys, but in our group at UT Southwestern, we're talking about the days of returning to normal and what is the clinic going to look like in June, July, or whenever that's going to be. So one of our viewers asked, how will you be restructuring your clinic? For instance, how much telemedicine, how much face-to-face visit once we get back to normal business? And what would you advise people as far as keeping patients and staff safe during that era?
Well, I think telemedicine is definitely has a place, and I was a skeptic, being a bit of a technophobe Luddite as I am. But I think I think it has a nice place, and I think it's going to replace a lot of my charts, where someone asks an essay question in 5 parts. And, like, well, you don't want to be a bad person and not answer them, but it takes a very long time. That's a televisit. That's a telephone visit or a video visit in the future. We're also starting to open up again. And I think a big problem that probably all of us are going to have is that outside of concierge medicine, waiting rooms are not designed for social distancing. They stack them in like the F train in our clinic, and you certainly can't do that now. So their plan is to bring in new patients and still try to keep the video visits for the return patients for a little while till things blow over completely, or we sort out a better way to do it so that people aren't sitting packed into a small room.
Yeah, we're making plans for how patients are going to come in. Very few people in the waiting room, and how you run flow to accommodate that. We're looking at a hybrid where we're going to, like just like you're saying, a certain amount of telemedicine. It's going to naturally fall to those who are good at it and can make it profitable, and those that really want the face-to-face and want to bang on a keyboard and touch every joint, then it's going to work out in the future, but I believe it's going to be a mixed model as we go forward. Andres Caseno, one of my partners here at Southwestern, asked, which do you think is worse, the cumulative damage occurred by steroid use or the organ damage incurred by either low activity or flares of activity, which if you had to bet?
Well, the problem is for some patients it's A and some patients it's B, and that's what you were pointing out, Jack, is we don't know. If a patient had a flare of glomerulonephritis because you stopped a small dose of prednisone, boy, you'd not be happy with that. But if someone got AVN and you think, geez, if I could have stopped the prednisone earlier, maybe they wouldn't have gotten it. But we don't know which is which patient, and both things can be possible and both things can be very serious.
Neil Stahl asked about Qod prednisone dosing. A blast from the past, a goodie but oldie. No adrenal suppression. It works for me. Am I treating my patient or myself? He thinks the patient. What do you think?
Well, it doesn't matter who you're treating. It matters who you're billing. So don't be billing yourself. There's no win in that.
Makes sense.
No, I love the every other day. And like I said, if I have somebody on 5, and I want to taper them, I'll ask them and say, look, we can go to 4 and then 3 and then 2. And sometimes you get that look like, yeah. And so, okay, what about 5 one day, 2.5 the next, 5, 2.5, 5, 2.5, and go to it every other day. I love that regimen.
Yeah. Another question of whether we think this data is generalizable to populations who are on more aggressive therapies, like everybody's on mycophenolate. I don't think we learned anything from this particular study about who you can best do this in.
No, they did have some people on mycophenolate. I'm gonna pull the numbers to see what the percentage was, like 13% or something like that. That stayed on the mycophenolate. 10% were on methotrexate, 3% were on azathioprine. So there were a small minority of people who were on those. But yeah, if 100% of the patients were on mycophenolate, would you be more successful tapering?
Our buddy David Borenstein in Washington says in 1993 he wrote a paper. He provides a citation, American Journal of Medicine, volume 94, page 258. About the recovery of the HPA axis in RA patients on steroids. Every patient on 5 milligrams or less had an intact axis. Patients between 5 and 7.5 were marginal. Everybody at 10 had a suppressed HPA axis. I
got to see that paper. Another old paper that would, you gotta bring them back from the archives. That's actually great. I want to see that. That's very useful information.
1993. You're going to have to look on that floppy disk you were talking about earlier to find that one. Let's see. FB3, that's meant for me. The question is worse. Which is worse, prednisone or the disease? Boy, isn't that like narrowing it down? Thank you, Danny, for asking that question. I think in the end, lupus is worse than prednisone, but boy, they're neck and neck, aren't they, when things are bad?
Yeah, it's an individual patient. Could be either.
Vivian Sue, New Jersey asks, what do you do with younger patients below age 40 who have osteoporotic fractures of the spine due to long-term steroid use? Do you push as hard to get them off steroids? Could you do this kind of experiment in people like that?
Well, I think it'd sure be hard in someone with osteoporosis to do anything but have as your goal to get them off the steroids. I think it's, the steroids are so bad for bone health in so many different ways, from calcium absorption to vitamin D processing through the effect on the osteoblast and the osteoclast. So they're bad all the way. Are they this bad? Is there a dose of 4 or 3 that would be safe? We don't know. And with not knowing that in that person, that's such a big risk. I think you really do have to push.
So Eve Scopolitis writes, and Bob Dylan wrote, how many roads must a lupus patient walk down before it'll burn out? Do you believe that lupus burns out?
I think that it does, and I think it's interesting. In this study, the mean age was 42. 90% were women. I think as they go a little longer in the disease duration, when they go through menopause, there's two things. One is the hormonal change of menopause. The other is that many of them will have had lupus now for 25, 30 years. And I think you can see, you certainly can see some activity still, but I think mostly it does become quiescent.
Yeah.
Now, is it the hormonal change or the burnout because they've had it for 3 decades? But I think it does become less active over time.
Is this right that the NNT on this is 5 to prevent a flare? Seems about right.
Yeah, I'd have to get out my pencil and
slide rule, pencil, the whole deal. Philip Theo says that Michelle uses an in-house whole blood hydroxychloroquine assay. She believes that the commercial assays that are out there are not reliable, and that's one of the problems. I think we should be using more hydroxychloroquine monitoring of blood levels. The question is, are they available and are they reliable, and can you use the commercial ones? Well, I think Philip and Michelle are telling us that you got to be really careful about what you ask for here.
Yeah.
John Goldman says, P is for prednisone, or is it for poison? Okay. You think the time-release chronic steroids are better in lupus or any other condition for that matter, or is steroid, the cheaper the better?
Yeah, I've not been convinced that this is older than you and I, which is saying something. The goal, how much time in rheumatology has been spent looking for a safer prednisone, and the trouble is because the side effects are not actually super common. The biggest ones that we worry about, and they take longer times to develop, like the osteoporosis. We don't know that we have a safer one. It'd be great if we did, but I'm not convinced that you can really dissect or dissociate the good effects of prednisone from the same mechanisms resulting in the toxicity.
Mm-hmm. Let's see. Joe Flood asks, how much do we worry that even 5 milligrams of prednisone is at risk for post-op infections? Where is the risk-benefit ratio? Is mild flares worse than post-op infections?
It's tricky and gets back to the individual patient.
Yeah. When Nancy Lane's asking about denosumab and tapering glucocorticoids, I think in patients who you have with glucocorticoid-induced osteoporosis, they're on denosumab, you obviously are going to try tapering, but I haven't seen data about the hazards of that. Have you?
No, and it'd be tough because there's just in those few variables, there's dosing and other issues. So it'd be tricky it'd be a big study to answer it. It's an interesting question for sure.
Yeah. Let's see, I think we got maybe a few more questions here. One question that's got nothing to do with this study, but has to do with COVID infection. Do you have any comments about our patients on TNF inhibitors or on IL-17 inhibitors? Do you think that it's any different than being on hydroxychloroquine or Actemra at this point?
I don't know. I think we're all going to learn when we see the data, especially from Italy, where they've had a lot of cases and a very similar approach to the treatment of patients as we have in the US and in Europe. You're not hearing a lot of really bad outcomes, but I think we will learn. We have to see the data. I wouldn't be surprised that it's not a tremendous risk, but we have to see the data.
Okay. All right, that comes us to the close of the hour. I want to thank Artie Kavnaugh for joining us and presenting this great paper. Artie, thanks a million. We're going to get you again to Journal Club in another few months. Tune in next week, everyone. We're going to have a great session with Len Calabrese talking about IL-6 and health and disease coming to you from the Cleveland Clinic. So until next week, folks, take care. Okay.